xuất bản cũng
me
như là
always
nghiên
wanting
cứu
to
động vật.
question things.
Dạ.
I always wanted
Tôi luôn
to
luôn
try out something
và
new,
chúng tôi sẽ
whether
cố
it's
gắng làm
clinical
cho
work.
mới là
So
những
a
công
lot
việc
of my
lâm sàng
research
và
work
vấn
is
đề
not
nghiên
lab
cứu
based,
của
it's a
chúng
lot
tôi.
of clinical
Và
research
như
work
vậy nó
because
liên
I
quan đến
like doing
lâm
translational
sàng.
work.
Tôi
So
làm
which
thích
is why
những
I
cái
work
nghiên
with
cứu
journals
mà
which
chuyển
also
dịch
do
đó,
a lot of
translational
translational
research.
work as well.
Đó không phải là nghiên cứu căn
So
bản,
in
nhưng ước
terms
gì
of
có ứng
my
dụng.
scientific
Và
profile,
đây là cái hồ sơ về cái
so
lý
these
lịch
are
về khoa học của tôi.
my research
Và cái nghiên
rankings
cứu
for,
của tôi
this is for 24. So in
2024.
terms of orthodontics,
Và
the
trong
global
cái lĩnh vực
research
ngành
rank is
thì
31st, and this is what
và đây
keeps
là
me
chúng ta
busy all
thấy
the time.
thì nó đang thay đổi rất là nhiều. Đây là những cái thành
So
tích.
then let's just
Và bây giờ chúng ta sẽ
talk
nói
about
về
the topic which I
là
wanted to share with you today.
thủ đề
So I
tôi
think
muốn
over
chia
the
sẻ với
last
các bạn.
day and a
Và
half,
cái
it's
trong
been
một cái
very
ngày qua,
enlightening in terms
các
of
bạn sẽ có những cái
Professor
sự khai
Marya
sáng với
covering
những bài giảng của
in
giáo sư
vertical
Marya và rồi
corrections,
sự kinh tế
Professor
chủ đức
Kim carried
và
out
cái
class 2 corrections.
bác
So
sĩ
I
Kim
thought
là hạng
I'll
2.
change it up a little bit
Chúng
and
tôi
talk
sẽ đổi
about
như
class
là
3.
chút là tôi nói
So
về
the
hạng 3.
reason being,
Và cái lý
it's
do
very
mà
prevalent in
nó rất
Southeast
là
Asia.
phổ biến ở
So
châu
as you
Châu
know,
Á.
I think there's a
Và
very
tôi
high
nghĩ
prevalence
chúng ta
rate.
có một cái tỷ
I'll
lệ
show you
hạng
the
3 rất là cao.
statistics as well as we go
Và
on a little bit.
và
So we
chúng ta
have a very
sẽ
high
nói về đó
prevalence
là
rate
một
of class
cái
3, which is
chúng
why
ta
it's
có
very
cái hạng 3
important
rất
to
là
know
nhiều
how
về
to manage this.
về cái thống kê.
So for
Chúng
me,
ta chính vì
the
vậy chúng ta
most
cần phải biết cách điều
important thing
trị.
in managing
Và
class
tôi
3
nghĩ rằng cái quan
is
trọng
the
nhất khi
diagnosis
chúng ta
itself.
là
Because
điều trị
there
hạng 3
are
là phải chẩn đoán đúng.
umpteen number of
Và
techniques,
chúng ta có một
there
số
is
cái
a
kỹ
lot
thuật,
of biomechanical
có
options
nhiều cái lựa chọn
and
sinh học
different
khác
kinds
nhau
of
và có
appliances.
nhiều
You
cái
have
kỹ
fixed
thuật khác nhau.
appliances, you
Và
have
khi chúng ta
aligners,
có cái kỹ
you
thuật cố
have
định, chúng ta có
correctors,
aligner, chúng ta
you
có
have
corrector,
many options.
những cái
But
cái
it
kỹ
all
thuật khác nhau,
starts with the
nhưng tất
diagnosis
cả đều phải
itself.
bắt đầu với cái chẩn đoán.
So again,
Và một lần nữa,
then if you just go
và
by
nếu
data,
chúng ta đi
you should
qua
just see
đây
class
thì chúng
3
ta sẽ thấy
with a
là hạng
relative
3
discrepancy
và
between
nó
the
có cái
maxilla and
sự
the
mà sai
mandible.
biệt giữa hàm trên
So
hàm
whether
dưới.
it's, we
Và
have two terms
chúng ta có
which
hai
we
cái
call
thuộc
it
từ
absolute or
và
relative.
chúng ta có là tuyệt
Absolute
đối
would
và
be a skeletal case where
đối
you
tức
see
là
a
do
proper
cái xương
discrepancy in growth
và
between
như
the
vậy
maxilla
nó
and the
có thể là
mandible.
do cái sự xáo trộn
Whereas
trong tay
relative
tương phản hơn.
discrepancies show
Còn cái
up
mắc hay
with
hòa tương đối
pseudo
có nghĩa là
problems
cái
with
vấn đề về
minor
giá
constrictions.
với
And then,
có một cái sự
most times, if you notice, you will see that class 3 tend
khi
to
nào
be
mà
much
chúng ta
more severe
có
than
hạng 3
class 2
rất là nặng
because these also
và
have
bởi
an
vì nó
associated
có tương liên
centric
quan đến
relation to centric
và
operation
cái
shift, which causes many
ta
of
là
the
trường
class
chức năng
3s to
giữa
look much more
làm cho
severe
cái hạng 3
than
trông
they
nó nặng hơn
actually
cho
are.
cái trường chức năng từ giữa
So
các
for us to manage this,
để có thể điều
what
trị
I
những cái này.
normally see
Và
in
những gì
terms
mà
of
chúng ta
let's
thường thấy
differentiate
đó
between
là
ideal malocclusions,
và
there
cái
are
sự
4
lệch
or
lạc
5
so
kinds
với
of
cái
differentiation.
khớp cắn bình thường.
One, the skeletal
Và thứ nhất
discrepancy,
là bắt hệ hòa
whether
xương
there is one
và
or
cho
not.
dù nó có thể
So
là
there was a
cái
classification, you will see lots of
duy nhất hay
classifications
không.
of class 3.
Chúng ta
But
có
some
cái
of the
sai
relevant
khớp cắn
ones
là
are,
xương
there was one given by
và
Marya,
như vậy có một cái
which
nghiên
just
cứu
broadly
phân loại của
classifies
Marya
it into
thì có
skeletal,
thể chia
muscular
các
and
cái
dental.
mà cái nữa
Which
là
for me is the
răng và
easiest
là
way
cơ.
to broaden
Dạ.
our knowledge
Và
about
như vậy
managing these class 3.
thì đây là cái giúp chúng ta mở rộng
Then
cho
we
cái việc mình
identify the
chẩn đoán.
cause.
Sau đó chúng ta
So for most of you,
xác
because
nhận
you're
được cái
practicing
nguyên nhân.
orthodontics, so I
Và
understand
khi chúng ta
that you
nghiên cứu
already know
làm
the cause
cái
and effect
dịch
relationship.
nha thì chúng ta
Which
cần
means
phải
we, a
quan
lot
tâm
of
đến
class
cái
3s
quan tâm
come up
quan hệ
with the
nhân
lower
quả
lying anterior
và
tongue posture.
có thể là
So
do
why
các
we
cái
have to
tầng
correct
mà
the
đẩy đường
effect, which is the
và chúng
mandible
ta
being
sẽ
relatively
nhảy như
forward.
vậy và đưa
And
cặp
second, we
dưới
also
cái
have
này
to
nó là
find
trên
ways
dưới
of
ra trước
maybe expanding the
và có thể
maxilla,
là phải nới
training
rộng
the
cái
tongue in some
hợp lý
cases,
hoặc
so that we can get a better
và như vậy
posture
chúng ta sẽ có
and
cái
more
thể tốt
stability at the
và
end of
cái độ
treatment.
ổn định của kết
Then
quả.
we have the
Và
diagnostics.
sau đó
So
chúng ta
again, it's
có
very
chẩn đoán
essential.
rồi.
I'll
Cái này
cover
rất
these
là
in a
quan
little bit
trọng
more
và
detail
chúng ta
as
sẽ
we
nói
move
về
ahead.
sau. Thì chúng ta
Then we
đi
have the
tiếp.
extraction, non-extraction
Và bây giờ chúng
decision.
ta điều trị
So
về chỗ
again,
răng không chỗ răng.
if I just use references, so according to Profit, which is the standard textbook, there are limits to both extraction versus expansion. So we don't favor either,
và chúng tôi
but we
có
go more
ủng
by
hộ cái nào
what we
hết.
see in terms of
Và chúng ta
diagnostics
thấy
in a
là không phải
particular
là chẩn
case.
đoán cho đúng, tức là
And
cái
then last
nơi
is
trong
the
thấy
option
chỗ
for
không chỗ.
camouflage.
Còn
So
rồi chúng ta sẽ
again,
điều trị ngụy trang.
in Cambodia, till about 2 or 3 years back, we didn't even
Và
have the
2-3
option
năm nay chúng ta
of
có
surgery. So
những
most
cái
of our
phẫu thuật.
patients were referred to
Và những bệnh
surgical
nhân đó chúng ta
centers
sẽ
in Vietnam,
đến cái trung
Thailand,
tâm
Thailand,
phẫu
or
thuật ở
Korea.
Việt Nam,
So depending on the
Thái Lan,
patient,
Hàn
whatever
Quốc
it is, we
và
just
Trung Quốc.
refer them out.
Và cho nên
But
là
then
Nhưng
If you notice yourself, most
và nếu
patients
các
who
bạn
come to
mà thấy
us,
bệnh
they
nhân
don't
đến với
really
chúng ta,
think of surgery. There are most patients would happily choose camouflage if that was an option. And for us as orthodontic practitioners, it's very important for us to know if we are carrying out camouflage, is it going to be stable? If it's going to be stable, how does it look on the patient's profile? Does the patient get a good enough profile change or not? So for me, this is the most relevant classification. So in fact, Professor Peter Nyan was just here for the WIOC. So for those who like additional reading, you could just read this more in detail. But it essentially talks about three very basic types of class 3s, which is an osseous or a skeletal class 3, which includes an actual discrepancy between the growth of the maxilla and the mandible. We have the muscular class 3s, we also refer to them as pseudo class 3s, we call them habitual class 3s, functional class 3s. So they have many names actually, because in these are more or less very similar to class 1s, but they have an associated mesial shift. So this is because of let's say premature contacts. It can be because of early loss of some of the deciduous teeth, causing slight mesial tipping of the posteriors. And then we have the dental class 3s, which are relatively easier to treat because there's no underlying skeletal discrepancy. So these are easier to treat with different kinds of techniques, depending on whether they are associated with crowding, whether the patient is looking for a profile change, and so on. So if we just look at a pictorial presentation, you can see that we have class 3s. You can have a component with a maxillary protrusion and mandibular retrusion. These have a limit in terms of a negative A and B angle, usually in excess of -4, -5. So these are preferentially always treated with surgery. What we try to treat mostly in our practices would be either a type 1 or a type 2. Type 1s usually come with a normal maxilla and a mandibular protrusion. Type 2s would be varying between a maxillary retrusion and a normal mandible. So for us, it's very important to first look at what is our classification. Then, if we broaden this out, so we just manage these very easily in terms of just identifying. Our treatment plans are usually based on whether these are true class 3s or pseudo class 3s, whether we have a maxillary deficiency, mandibular excess, or a combination of both. So let's say you have maxillary deficiency. If it's a growing patient, we try to bring the maxilla forward or we try to expand. If it's a mandibular excess, we try to think along the lines of either using class 3 elastics to try and push the mandible back or carrying out extractions in the lower arch so that we can get to a more positive overjet. And then the last would be a combination case, which normally tends to go in for surgery. We also have a protocol we developed specifically for managing pseudo class 3s. So I'll show you the paper reference as we go on a little bit. So I've been working in this area specifically just because we are very exposed to managing class 3s. So these are some of the more relevant papers which we've published. One was in the Asia Pacific Orthodontic Society journal. So this was talking about management of periodontally compromised class 3s. So I'll show you a case reference based on this as well. So again, we use TADs for these because whenever you have periodontally compromised anchorage, it's always better to look at using skeletal anchorage for reinforcement. There was another paper that we published in Orthodontic Waves, which is the official journal of the Japanese Orthodontic Society, which talks about molar protraction on an adult patient. So I'll again show you one or two case examples of these protocols that we've developed. And then this has been one of the more cited papers that we developed, which was managing a lot of these class 3s with asymmetry. So you will see, because of the differential growth of the mandible, there is always an associated midline shift, mild asymmetries with these class 3s. It can be either a midline shift on the face Sometimes it can be in forms of a vertical problem. So we developed a lot of strategies and protocols for managing these, and this was eventually published again in International Orthodontics. And then this was a single author paper which I published a few years ago, which was in the German Journal of Orthodontics, Kiefer Orthopädie, where we used vertical corrections. So if for those who are aware about the McNamara's protocol, which talks about a lot of vertical corrections, which brings about a differential change in the complexity of class 3s. So we used a lot of vertical correction in this using just a very simple high placed transpalatal arch, which we used to intrude the upper segment and brought about a lot of change as well as a rotation of the mandible to correct the class 3. And then in recent years, we've been working a little bit more on digital protocols, use of differential appliances. So I'll show you examples of those as well. So coming back to why we wanted to discuss this is simply because for those who practice here, you would already know there's a very high prevalence rate in Southeast Asia, which is most countries it ranges somewhere between 12.5 to 26.67%. But if you compare this with, let's say, the other populations, so in the US or Europe, you will measure, I think because I've been in the UK, so if you visit, you will literally see every second person is a class 2. So that's their natural profile. So it would be very rare for you to meet a class 3 patient in the United Kingdom. Then again, in, let's say, if we talk about African Americans, their classic profile is bimax. So it would be very common again to see bimaxillary profile patients there. But now when we move towards the Asian side, if you talk about Japan, you talk about most of Asia, you'll see the prevalence rate starts to increase. So we did a preliminary study in Cambodia. We found out around 35% of our patients were class 3s. But this is with an aberration because we still have to calculate this against a broader sample. But our initial results, and I'm very sure it's similar in Thailand, it's in excess of 26%, and I'm pretty sure there's a very high prevalence here in Vietnam as well. So then, now why our treatment plans differ? As you would have seen from Professor Nanda and Professor Kim's cases, you saw a lot of mandibular advancement. Because in the Caucasian population, a lot of times you would see it's very common to see mandibular retrusion. So they have a lot of chances to see mandibular advancement. They think in terms of class 2 elastic use. For us, we have a very straight profile in Southeast Asia. So in Southeast Asians, just to give you a brief difference, the nasolabial angle for the Caucasians is supposed to be 98 degrees. So do you all watch Netflix? I'm sure literally everyone watches Netflix, right? So if you watch Netflix movies, you will normally see most of the female actresses have gummy smiles, they have long noses, and they have thick upper lips. So which makes it very favorable for them to have an increased nasolabial angle. And gummy smiles of 3 millimeters or 4 millimeters look very aesthetically pleasing on those actresses. Now imagine one of your patients having a gummy smile of 3-4 millimeters with a short nose, a small upper lip, a thinner upper lip in volume. Aesthetically suddenly doesn't look pleasing anymore, right? So you imagine Southeast Asian patients having gummy smiles in excess of 3-4 millimeters, it almost tends to look like a case which needs surgery, right? So for us, these are some of the important factors. The other would be the lower lip profile. So whether it's a class 3, whether it's a bimax case, you will notice very often the lower lip goes ahead of the E-line very easily. So a lot of these patients come to us looking for profile correction. So we have to think along the lines of extraction to somehow get the lower lip behind the E-line. Then we have to also consider whether the patient has a gummy smile or not, and does the patient require extractions or non-extraction based treatment plans. So this also differs on one, the patient's crowding, patient's incisal angulations. There are many factors which decide whether we carry out treatment for a patient with extractions or without extractions. So one of, again, a very important piece of paper for us to decide the lip profile. So this was a paper which was published by our current WFO president, Professor Red, which talks about the best reference planes. So again, the most favorable planes are the E line as well as the Steiner's S line. So these are very accurate in terms of telling us whether how far is our lip beyond, and how much of your treatment plan is extraction dependent would also depend on the relative position of the lips with regards to the E line. So then, talking about, So there are 5 keys to managing most class 3s. So I'll break these down as we go a little bit ahead. So the diagnosis, types of brackets, occlusion plane, extraction versus expansion, and the anchorage. So if we identify these 5 keys, it becomes relatively very easy to manage most type of class 3s. So it's essentially 5 questions we need to answer. So let's talk about the first key. The first key talks a little bit about different factors. One, the patient age. So let me just ask a general question. So what age do you think we can start managing class 3s? 7? You're saying 7? Okay. Anybody else? So depending on the patient's problems, the earliest patient I have managed, and we have a published report on that, the youngest patient I've ever managed was 3.5. So which was a patient coming and looking for, she was a patient who was getting bullied at school because she had hereditary oligodontia, which means she was missing a number of teeth and her lower teeth had moved forward, and she was just not wanting to go to school because she was getting repeatedly bullied at school. So we gave her a very passive appliance, which was a modified NANS with acrylic teeth, so that we could give her teeth and also put her lips in a better position. So that case report is easily available, so I won't go into details, but that's the earliest patient we've treated. The oldest one has been 61 years old. So depending on the patient's bone condition, the incisor roots, we can decide to start the patient's treatment. With class 3s, there's a very high genetic predisposition. So which means whenever I have a growing patient, I always look at the mother or the father's profile. It gives you a very good idea of how much the mandible is expected to grow forward. It has a very high genetic correlation. Then we also look at the degree of crowding, whether we can resolve the crowding without extractions, with extractions, do we distalize, do we expand. So again, there are limitations to moving the incisors, whether it's outside, whether it's inside. The minimum marker for us to take up a case for class 3s is whether we can achieve an edge-to-edge relation or not. If you feel confident that you can't reach an edge-to-edge relation, it's always better not to start that patient. And then the last would be the amount of dento-alveolar compensation, or how much are the incisors retroclined, which becomes more relevant and important when we manage skeletal class 3s. So these are some of the factors which we have to take into account for diagnosing. So there are a very common associated features with different kinds of class 3s. Wherever you have a retrognathic maxilla, you can see that the molars are class 3s with the anteriors edge to edge. With the longer or prognathic mandible, you might see crowding in the lower region. And if you have a combination, you will normally see anterior crossbites. So they tend to look a bit more severe. Now, it also adds up with the patient's age. So if your patient is younger, it becomes easy to manage most types because we can carry out early correction. If your patient is an adult, now it becomes a bit more complicated. So this is one aspect of deciding what our treatment plan would be. So then it comes to the Moyer's classification and how we manage patients based on that. So the simplest way to decide your diagnosis whether a patient is skeletal or pseudo is just to look at the patient's profile. The second would be to look at the teeth. So normally, if you see a skeletal patient, they would actually have a transverse discrepancy, and you would see that the mandible tends to be a little wider or more developed. When you consider a skeletal class 3, usually you will see that it's very compensated, which means you might have a lower incisor retrusion, you might have crowding, and it looks very skeletal class 3. So now the easiest way is you just ask the patient to retrude the mandible. If your patient can retrude the mandible, you will see that the patient undergoes a profile change. It normally means your patient is a pseudo class 3. In a skeletal class 3, there is no way that the patient can retrude backwards. Now there are also, the latest classification says there are also skeletal class 3s with a mild functional shift, which means your class 3 tends to look a little bit more severe. So they might be only able to go back marginally, just let's say 1 or 2 millimeters back. So you get a very mild profile change, which means that we can carry out treatment, but we also need to correct the functional problem. So we have the classic skeletal problems, we have the pseudos, and we also have the skeletals with a slight functional shift. So for us, once we establish a diagnosis, the next thing is to check what brackets do we use. So again, to get to one destination, you can go by flight, you can go by car, you can go by a ship. So similarly for us, it becomes very important at times to decide. So for me, I have a very simple philosophy how I decide. If I'm thinking of expansion or if I'm thinking of non-extraction, I would normally go in for self-ligating brackets. It just because of the expanded arch form, the brackets, specifically I like to use passive over active just because of the nature of the brackets and the wire systems. However, if I'm thinking of extraction-based treatment plans, I always favor conventional brackets as a rule, because if I'm carrying out retraction, it gives me more control. If I normally like to use smaller slots when I have to retract, because I can use wires where I can control the torque and I can carry out a lot of bodily movement as I like, which is one of the things I'm not satisfied with self-ligation. The third thing which is important in terms of stability is the occlusal plane. So I don't see this plane being brought up in many conferences or even many discussions. This is a line which is called the Camber's line, which literally runs from the base of the nose to the tragus of the ear. So it's very important for us in terms of stability. So if you notice, most of your patients who come with vertical problems, their occlusal plane is not parallel to the Camber's line. Whereas this is one of the lines which decides whether we have stability when we carry out functional activities or not. So at the end of the treatment, one of our objectives is to try and get the occlusal plane as parallel as possible to the Camber's line. This will help you a lot in terms of stability. Then we have the fourth key. So this is how the Camber's line looks on the patient's facial profile. So our preference would be to get the Camber's line as possible or as parallel to the occlusal plane. This will help you a lot in terms of long-term stability. So again, the importance of this is this helps influence whenever you have dysfunction, especially class 3 patients do come with a lot of dysfunction. Let's say a class 3 with a tongue thrust, a class 3 with an open bite, they usually have dysfunctional occlusion. It tends to become more severe because the masticatory activities influence how the growth takes place. So this will in turn influence facial growth as well as intra-arch stability. So when we want to stabilize the occlusion again, we also have to look at ways in terms of how we make it parallel again to the Camber's line. So again, there's a reference here for those who want to read this. So this was again published in Progress in Orthodontics. Then the fourth key is extraction, non-extraction decisions. So one, it depends literally on the canine and molar relations. For me, it's the easiest way to decide this is I normally check how far is my canine ahead from a class 1. So my priority is always to look at canine guided occlusion, specifically for more severe cases. So over there, I try to check if my canine is just 2 or 3 millimeters away from a class 1, I think of distalization, I think of elastics, I think of IPR, or even removing wisdom teeth. But if my canine is further away, I normally think along the lines of extractions, and then will be the next answer, which is what kind of anchorage to use for space closure. Then we also consider the patient's profile. In terms of profile, specifically the upper lip profile and the lower lip profile, the patient's IMPA. So in class 3s, we more or less expect always to have an IMPA less than 90. The marker would be 84 degrees and above. Anything above 84, we can try and manage it with camouflage. It might look still a little bit retrusive after treatment, but that is the minimum benchmark for us to be able to do ortho treatment. And the last is the extraction index. So this is a relatively newer term which came. It takes into account the overbite depth indicator and the anterior posterior dysplasia index. So in simple language, it just takes into account the anterior posterior problems, the vertical problems, and computes whether it is okay to manage a patient with extractions or without extractions. And then, so in terms of us deciding whether we want to expand or not, so one of our papers was recently published in seminars in orthodontics. One of the guest editors was Professor Kemos here a while back. So in terms of us managing patient without extractions, we've been working a lot with different designs of Marya expanders, trying to see what works best. So we developed brand new digital workflows for Marya design. So we were the first ones to come up with focusing on the lab-based designs for Marya expanders. This talks a little bit more about how proficient is your lab in making a Marya appliance. So depending on the lab's functionality, we have a base level Marya where you can just solder the appliances. We have the next levels, which are labs which are very good, who can actually 3D print the arms and you just do basic soldering. The third iteration, you can actually 3D print and 3D design the whole thing. So this was just recently published about 6 months ago, where we have different iterations of these expanders. So we developed different digital workflows because you can't really have these manually made, according to me. So with time, you will always get more data. Because one of the problems with inefficiency related to Marya is, if you don't have CBCT and scan integration, you really cannot decide very properly where to place the screws. What we try to do is digitalize the whole process, so we pre-plan where to place the screws, where is it more efficient, and we also we're currently in another project where we're trying to do stress analysis of digital versus manually placed screws. So when you know your ideal positions, it makes it very efficient as well as very effective in planning these appliances. So then coming back to the last key, which is anchorage. So now that you know whether you're carrying out extractions or non-extractions. So extraction-based plans, one option is to use mini screws or any form of additional anchorage. If not, I was originally trained in fluid mechanics, so we try and look at options on how to bend, develop the anchorage. But then there is a third form, which is, let's say now you're neither carrying out anchorage development or using tats. You tend to use the maxilla as a form of anchorage, and we use class 3 elastics, or we call it interarch elastics. So for those, we try to reinforce the maxilla or the maxillary teeth for that matter, because it's a stationary bone and it's attached to the skull. So it makes it very easy for us to use the maxilla as a reference form of anchorage, and we use class 3 elastics. So once we answer these 5 keys, you should be very clear on how you can manage that kind of class 3. So you've already decided the diagnosis, you've planned whether you need extractions, you've already decided what form of anchorage you're using, which makes the next part of the treatment planning process very easy. So again, I like my motivational quotes. I have habits. So for me, it's literally been a habitual thing. I like my workstation very organized. My work desks are very organized. So the more you're organized as an orthodontist, really it helps. You tend to develop habits, and those habits keep you going always. So let's talk about treatment options. So I'll talk about two diverse treatment options. One is for the skeletal counterparts. The other would be for the dental and the pseudo class 3s. Okay, so the first option would be for the camouflage patients, where we have to carry out extractions. Now, because of the guidelines which are set in place, we are really limited in terms of the arch length tooth size discrepancies, how much can we retract. Because if you look at your cephs, you will see that your mandibular alveolar bone is really thin. So we literally have that thin envelope in which we can move teeth from one place to the other. So we have to worry about the position, translation, the torque. There are many things which we have to consider when we are moving teeth, especially in that very thin envelope of bone which we have. So the contemporary extraction guidelines, this is laid down in Profit, which is the standard textbook. It says, whenever you have 4 millimeters or less of arch length discrepancy, you can carry out cases without extractions. Just wire expansion is usually enough. When you have arch length discrepancies between 5 to 9 millimeters, now you look at, these are what we call borderline cases, because these depend on different factors such as the amount of crowding, patient's profile, incisor angulations. So we consider all of these, then we decide whether to extract or expansion or gaining space with IPR, distalization. This is the borderline area. But wherever you have discrepancies of 10 millimeters or more, there is literally no doubt that the patient will have a convex profile. The patient might have a very protrusive lower lip. So we generally tend to go in for extractions to correct the profile. Okay. So in terms of treatment options, again, there's a very important reference here. So depending on the severity of the occlusion, we either look at getting the canines and molars to class 1 or only choosing between getting the canines to class 1. So if you've studied prosthodontics, you've studied occlusion, you will always hear the term canine guided occlusion, canine guidance, anterior guidance. You never really hear the term molar based occlusion. But molars, of course, are our reference points. But in Southeast Asia, this becomes compromised because you will see a lot of patients with missing molars. So I doubt you will see missing molars in European patients or American patients. So which is what complicates our problems a little bit, and we give preference or priority to class 1 canines and wherever possible class 1 molars, but if not, we try to go in for a functional post-orthodontic class 3 occlusion, which means your molars essentially lower molars will be always ahead. So to show you some examples of the references we've talked about, some of the challenges that we have. So I'll show you one of the patients who was, again, she was very compromised when she came. She could not afford surgery. She had lots of decay in her mouth, so which made her treatment planning very complicated. So when she started out, I think it's, okay. So one of the references that I showed you before was talking about molar protraction, and the second was talking about periodontally compromised cases and especially moving teeth on thin ridges. So the patient came in like this. So you can see she has a under-supported upper lip. It's because of her negative overjet. Her lower lip was very protrusive. So she has a profile which ideally would be suited for surgery. But again, the patient didn't have the option to do surgery. And second, she was not willing to travel. She was very fixed on getting orthodontic treatment. So if you think this doesn't look bad, this will make it look worse. So when she came in, you can see that she has her upper incisors are retroclined. She has a negative overjet. She also has lots of decay. As you can see, she's missing her upper arch first molars, lower arch she's missing one molar here, and she had multiple restorations. Oral hygiene was not good, so she was compromised in a number of ways. So we had to think in terms of how to manage this. So we had different treatment options. We thought of how we can fix this. So one, whenever you need this much correction or your A and B angle is lesser than 2 degrees, it's always more favorable to use mini screws or tabs. So that gives you much better control when you're retracting, and it also helps you stabilize the lower arch in terms of occlusion. So what we wanted was to intrude the lower molars a little bit so that we could get some occlusion correction there. Upper arch, we just wanted to align. And then see, we wanted to retract the lower arch till we could get the patient to a positive overjet. And then any remaining space, we wanted to protract the posterior so that we could finally close all spaces if possible. So this was just to show you the severity of the case. This is what we started out with. So you can see the Ceph and her facial profile. So both the upper lip is very hypertonic, the lower lip is very protrusive. So we decided our treatment plan and then we started working towards it. So when we started closing spaces for her with screws, then we started to protract the posterior segment for her. But as you can see, one of the problems that you will encounter when you over-retract, with class 3s, they always tend to lose a little bit of torque or retrocline. So now, this was one of the things which we wanted to fix, because we realized we never wanted to send the patient like this with, as much as possible, to send her with this kind of unstable occlusion. So we decided to add positive torque. We wanted to upright the incisors and see if she can finish in a better condition. By this time, if you look at her occlusion, seems very satisfactory, but we still wanted to settle this more. So we carried out, we gave express torque. So you see the difference now when the incisors upright for the same patient. You start to see a much healthier level of gingiva here. You start to see the gingiva go back up. But this essentially took us about 6 to 8 months of just gentle torque expression every time. So it took us a lot of time to see this much change. Then we started to resettle her occlusion again in the posteriors. We placed our Kobayashi ties. One of the changes that I normally employ in terms of elastic use, I like to have my class 3 elastics most times, especially in transverse discrepancy cases, they run from the lower arch to the upper palatal surface, because that helps you give you somewhat of a crossbite effect as well. So especially when your molars are a bit narrower, if you use the elastics to the palatal surface, it also gives you a crossbite effect. So that will also help you correct this a little bit. And then finally, once we settled the occlusion, closed all spaces, so we were able to complete her treatment with class 1 canines. So on the right side, we were able to replace everything. We were able to protract everything to finish with class 1 molars. On the left side, we decided to compromise the relation and just finish with a functional post-orthodontic class 3 malocclusion. And this is how much of a profile change we got on the patient. So you can see her smile changed a lot. So these class 3 patients normally come with an almost negative smile arc in many cases, or a very flat smile arc. So we also wanted to make sure she feels confident. So as I think Professor Kim mentioned a while back, so orthodontic treatment, there are lots of fields in dentistry when you can treat a patient, patient pays you immediately, you finish the treatment, patient goes home. Orthodontics is something which you can see in many ways as life-changing for patients. We invest time, we invest effort, we use our brains a lot. It takes us a long time. This took us almost about 32 or 33 months to finish. So it took us a long time, but then when you see that change in profile, it's very satisfying. So this was her pre-treatment smile, her mid-treatment, and her post-treatment smile. So you can see she has much improved smile now. So one of the problems also I will tell you is, so this is her pre and post, you can see here. The major drawback with managing patients with camouflage is, so if you know about divergence, so most class 3 patients come with anterior divergence, which means that the forehead is slightly behind, the chin is always forwardly placed. So the problem with managing most class 3 camouflage is, initially when the patient comes, you will notice that the patient's lip and the chin always tend to be in a straight line. So the patient doesn't feel that the chin is very prominent. But post correction, you will always hear the patient say that the chin tends to become a bit more prominent. It's because you've managed to correct the lip profile. So we haven't done anything here, but just because the lips have gone in, now the patient tends to feel that the chin is more prominent. So the end solution is again that she can do an outpatient procedure if the patient is concerned. But most patients with this much of change are really very satisfied. So most of them may or may not want to go in for any aesthetic correction. The major difference is also financially. Let's say if the patient does surgery, it would have cost her anything between $15,000 or $10,000 to $15,000. A mentoplasty is an outpatient procedure with just general local anesthesia. It's an outpatient procedure. The patient is in and out of clinics in about 1 to 1.5 hours. We just do a small cut here, trim off the excess bone here, and then finish. So it's essentially outpatient and it's less invasive. There are less chances of that going wrong. So that is what you can advise patients who are still looking for chin correction after camouflage treatment. So this was her pre-treatment occlusion, and this is her post-treatment occlusion. So it's very essential for us to get as much uprighting as possible for the incisors, so that we can get the proper torque, proper tip in place for us to be able to finish this in a more stable manner. And this is just her progress. So for complicated patients, you can actually see the mini screws here in the middle, Seth. So we use the screws in an effort to just stabilize the lower occlusal plane, because when you try to protract the molars, you will sometimes see that the molars tend to over erupt. Then this is just her progress. Okay. So that was one patient where we needed to close space. I'll show you another example who came in with a severe crowding, deep underbite, and an impacted canine. So again, this patient was referred to us from another practice. He had already undergone 4 extractions. So when they started to plan treatment for the patient, they noticed that on the right side, both the canine and the premolar were missing. So which means the patient had one impacted canine. I'm not sure if the pointer shows you, but on the right maxillary segment there was an impacted canine. So they decided to refer the patient to us for further treatment. So now this is a classic class 3 patient. You can see the lower lip is very protrusive, the upper incisors are retroclined, there is upper arch crowding. You can see the upper arch is very narrow as well. The lower arch has a little bit of crowding anteriorly, but you can see the curve of P is deep as well. So one of the computations we always do in terms of leveling these kind of patients is, for every 1 millimeter that we level the curve of speed, we normally expect about 4 degrees of anterior proclination. So I have the reference for that. I'll show you as we go on a little bit. So now my priority was one, to get the patient into a positive overjet and also see if we can manage the canine. So we decided to start treatment for this patient. So he also had mild asymmetry. So I thought I'll show you this. So you can see he has a slight deviation as well, which is again very common to see in class 3 patients. So we try to address this usually at the finishing stage. So this was his pre-treatment set. So if you look at his pre-treatment set, you can see the canine almost ready for takeoff. So the canine was very high placed. So again, I'll show you there are some research papers which talk about canine positions, impacted canines, whether we should bring them out into occlusion or not. So if your canine is, let's say on the mesial half of the lateral, there's about 91% chance of success. If it's on the distal aspect, there's a 91% chance or 64% chance of success. So what we try and always do is we try to improve the angulation of the canine first. We never try to bring it out into occlusion. So it's a stepwise process. So we started with just the analysis first. You can see this is the deviation from the normal. So sometime later, again you will see in a lot of slides, I really like wire bending a lot. So as much as possible, whenever I feel I'm in trouble, I'd like to bend. So it just de-stresses me. So I'm not very confident when it comes to using heavy night eyes for anything. I still like to bend whenever I feel there is something which I need more control over. So for the lower arch, we started with just canine retraction first, followed it up with use of closing loops. For the upper arch, this was my own design. It's not there yet, so I sometimes zone out on dental chairs, and my assistants and my patients both keep staring back at me. So it takes like 5-10 minutes. I will just keep drawing something to figure out what's good. So we designed this with slight tip backs on the distal aspects and the 3 helices just to make heavy wire very springy, so that we could just pull the canine a bit away from the root of the lateral. So this is not to bring the canine down. This is just to improve the angulation of the canine first. We just wanted to move it away before we decide to expose, bond and place an attachment to bring it down. So this was the first surgery that we did. We carried out just a small attachment so that we could just move it away. Then once it's moved away on the distal aspect of the root, we had to redo a surgery. So now we used a base 1825 stainless steel wire and a piggyback or an auxiliary, very small light night eye wire to slowly guide the canine down. For the lower arch, we were done with space closure, but again we had some challenges to address, which is one again. As I told you, when you retract, especially with self-ligation, the challenge is loss of torque. So again, we have to correct the torque. And then the lower arch was constricted because we were using a constricted arch form to retract the lower arch. So a couple of months it took us to bring down the canine. So once the canine came down, now we needed to get additional space. We wanted to upright the lower anteriors. So we removed the wires. We just went back to copper night eye wires, bonded the 7s, because we also wanted to gain some space posteriorly with a little bit of expansion at the end. So we just wanted to gain some space transversally. So we dropped the wire down, we bonded all the 7s, and then we reached the finishing stage. So at this point, we are mostly just settling the occlusion with class 1 molars, class 1 canines. We just placed very heavy wires, stainless steel, just to get some torque expression so that we could upright everything. You can see the patient's smile looks much better. His profile has changed completely once we went into positive overjet overbite. So this was his soft tissue profile after the correction. And this was how much of profile change we got. So again, you can get a lot of correction provided you have the right overjet, the incisors are at the right angulation. You can see much better lip support for the upper, and you can see the lower lip go back inside the E-line. So we can get a lot of soft tissue changes just with camouflage itself. And we managed to finish the patient with class 1 canines, class 1 molars, and positive overjet, and we managed to bring the impacted canine out into its proper position. So again, this roughly took us about 35 months of treatment. So these treatment times are usually longer. It takes much longer to, we encounter different challenges. So for me, normally just the time to bring an impacted canine from a higher position to a lower or the occlusion plane is roughly about 1 year to somewhere between 15 months. So 12 to 15 months is like my standard expected time. So we try to move the canine down very slow, because one of the drawbacks with pulling a canine down is you will see that maxillary anteriors flare out, and very often you will see that the canine starts to tip in and the roots go out. So which is what we want to avoid. So we try and keep as much control as possible, and we try to move it down very slow. So you can see this is his profile comparisons, and this was his pre and post. So in the beginning he couldn't really show his maxillary teeth. So he was trying to show all his teeth when he finished. So he's very happy. Now he's moved and he's studying in Australia now. So he was. This was a whole family of class 3s that we treated. So except for the mother, the father was a class 3, the son is a class 3, he has 2 twin sisters who are also class 3s. So they've just finished treatment 2 or 3 months ago. And so again, we try to keep looking at CEFs to check the angulations, we try to make sure we keep monitoring the positions of the lowers, and so on. So then, I thought I'd show you another example of a class 3 case with an anterior spacing and open bite tendency. So again, the reason why I chose this was talking a little bit just about the etiology itself. So again, if you look at this case, it doesn't look that bad. It's just like slight class 3 molars. Canines are almost class 1 itself. So the patient has a slight tongue thrust habit, which is why I thought it would be interesting to show this. So again, when you look at the tongue position, first in a class 3 patient, it becomes very important to evaluate the tongue. So whether the tongue is lower lying, whether the tongue is resting on the incisors, it makes a lot of difference in the end outcome. So we have these kinds of tongue thrusts look good. Patient tongue thrusts usually don't tend to look that good. So it looks very cute in cartoons, on animals, and so on. But then comes the important part on how do we diagnose a patient with the tongue thrust. So there are 2 tests which are very common. One is just the speech test. So patients who have a tongue thrust, there are 2 alphabets they never really say very clearly. One is S, one is F. So when you ask a patient with a tongue thrust to try and say S and F, just let them speak normally, and then in the middle somewhere ask them to say S and F. You will notice that they have a habit called lisping, which means the tongue comes between the teeth when they try to say S and F. So S would sound like F, F would sound not clear, which means this is one of the diagnostic tests. The second would be just an easier test is a water test. So we pull the lower lip down and just spray water with a 3-way syringe. If the patient does not have tongue thrust and a normal swallow, they can take the water in. But if the patient has a tongue thrust habit, they never develop the vacuum so that they can swallow. So you will see that the water will just keep gurgling and they can't swallow it. So this is the other diagnostic test which we use for tongue thrust patients. So now, once we confirm the patient has a tongue thrust, so how long do you think we can manage it in? Or what do you think is the standard treatment time? So again, one of the classifications says if a habit is mild, moderate, severe. So again, there is no clear designation on what is mild, moderate, severe. It's more of an age-based classification where they say younger patients have milder habits to moderate habits. But if you feel that the lisp is too strong, if you see a lot of spacing, that usually would be a moderate to a severe patient. So the classic classification says that mild to moderate patient only takes about 6 months, but severe patients can take almost 18 months of habit correction. Which brings me back to the point I mentioned in the beginning, which is talking about the cause and the effect. So if you close spaces, debond, patient goes home. But the cause was tongue thrust, which still remains. So if we haven't treated the tongue thrust, there is every chance the patient will develop spaces again. So we have to train the tongue to be going to a more posterior position, and at the same time we carry out management of the effect, which is closing the spaces. So then what we normally use for managing a tongue thrust, it's just a simple appliance, it's called a palatal crib. For mild to moderate options, there is another appliance, it's called a bluegrass appliance. So a bluegrass appliance looks very similar at the posterior part, but in the anteriors it has either a hexagon or a ball, and we just ask the patient to carry out tongue training exercises, but it's really meant for small children. It's not been found to be so effective in adults. So adult patients, we normally tend to use a palatal crib. So ideally for most adult patients, the minimum time I keep it is for about 18 months. So I normally go treating every patient as a severe patient. So if my treatment time is 2 years, I would normally just confidently tell the patient that this appliance stays in place for about 2 years. It's just okay to extend it. Sometimes you will notice when you remove the appliance at the end, if you still notice a lisp, we still ask the lab to add a small crib on the retainers as well. That will again go a long way in helping you stabilize these patients. But if you notice that the patient's speech tends to clarify, it becomes much more easier. So these days, these were the patients where we just used photographic records. These days, when we have patients with lower anterior spacing and if we see they have a tongue thrust, we actually do speech videos. So the patient can compare pre-treatment, mid-treatment, post-treatment, and they can actually visualize their own differences themselves. So now, what we do for patients with tongue thrust or anterior spacing, it's a very standard protocol. So we always try to close the 4 incisors first, and then we retract the canines. You can do it either with chains or you can use open coils. I tend to go with open coils on rectangular stainless steel wires because one, it gives you reciprocal anchorage. So the canines go back towards the class 1, the anterior space closes, and then you can just retract the anteriors using hooks. You can use any modality. I still prefer using loops a lot. So I would still just go ahead with anterior consolidation, close spaces, just start retracting the lower anteriors. Loop mechanics just tends to give more better torque expression for me. So with power chains and hooks, there is less surety for me. So whenever I use power chains, I'm really very stressed because sometimes patients remove chains, they break chains. Let's say the patient has a chain and the patient doesn't show back for 2 or 3 months. You will notice there's either midline shift, some of the chains might break off, or there's tipping. The reason why I do tend to use loops a lot is because it's a fail-safe mechanism. You activate the loop, once the movement takes place, the loop becomes passive. So if your patient doesn't show up for the next few months, it's still okay. So I just prefer this method for space closure. Secondly, it's frictionless, so there are less chances of root resorption, there are lesser side effects, and it gives you much better torque control when you retract anteriors. Specifically because you will see a lot of these patients come with a very thin gingival biotype. So on a thin gingival biotype, if you use hooks and power chains, you will notice you lose torque very easily, your incisors retrocline, your roots start to become more prominent. So which is why it sometimes helps to use this. And then we just carried out treatment, finished with class 1 occlusion on the molars and the canines. And so this was the difference. So we try and not change the arch form too much because whenever we're using the conventional brackets, we do make our own customized arch forms. So we measure the patient's arch. We have the standard straight wires. We use a turret. We make the arch forms. So it makes it easy to maintain arch forms. But this is for conventional brackets. If I'm using self-ligation, I would not do that. I would just use the arch forms which are provided with the bracket system. So, and this is just a composite image of how the whole treatment went. So we started again with habit. You should notice the way we place the height of the crib is, so we normally like to check the height of the crib to make sure that your tongue stays behind the crib. If your tongue is still passing through everywhere and contacting the incisors, it still doesn't work very effectively. So we can increase or decrease the height of the crib depending on what we see in the initial records. So we just carry out just normal treatment, space closure, as well as habit correction for the patient. So this whole process, again, the minimum time has to be 18 months. So I do recommend keeping it in place. If your treatment duration is around that, you can just leave it in place for the entire treatment duration. So then it comes to, so these were some of the examples of different kinds of complex castries, some are mild castries. So I thought of just showing you some examples of growing patients as well. So in terms of growing patients, we do use a lot of 2x4 appliances. So I really like these 2x4 appliances. Okay, so maybe we'll just show one or two slides and then we can have a short break. So I really like using these 2x4 appliances very early on. So the easiest marker to identify whether we use a 2x4 appliances, the root completion should be at least 2/3 or more than 75%. So if your incisor roots are more than 75% complete, you can bond and start with a 2x4 appliance. 2x4 usually implies that you're just using 2 molars and 4 incisors in each arch. So you can see like it's just very simple wires. It gives you very good correction. So if I have class 3 patients or patients with crossbites, I would just bond the upper arch, just correct the crossbite first. Thereafter, I just go ahead with standard wire sequencing, but I normally we don't need so much of torque expression. So we just stop at 1725 stainless steel, we don't go further. You don't need 18 or 1925s because there's no bodily movement taking place. So you don't need much more torque expression than that. So you start with the standard wire sequence, continue till you reach 1725 stainless steel and then you can stop. And then thereafter we just maintain this till you start to see the permanent teeth coming into their normal positions. So thereafter it's just maintenance, making sure it's proper hygiene, and you just allow, so you will see that the canine will actually just gently drop down into class 1 positions. So the early corrections help in a way where you can carry out a lot of expansion. You can actually minimize the risk for some of the or chances for extractions which would come if the patient is an adult patient. So if the patient was an adult patient and you saw this much of crowding and you let it persist, there's every chance this would develop into a full-blown malocclusion. So we like to start off early so that we can get a lot of early correction, and you can see that you will be able to manage a lot of class 3's non-extraction, which is our idea for starting as early as possible. So I think we can have a short break and then we'll continue. I have more cases to show you once we finish the break. Thank you.
Xin mời quý vị người Gia Lao trong ít phút để nạp lại năng lượng. Ban tổ chức xin thông báo chương trình video game để chúng tôi nhắc lại các bác sĩ tham dự sau những phút này sẽ không được đến. Ban tổ chức sẽ tổng hợp danh sách các bác sĩ tham gia đúng thể lệ cuộc thi. Bác sĩ nào chưa tham gia hoặc tham gia không đúng thể lệ sẽ không được đến. Đã tổ sẽ công bố vào cuối buổi học ngày hôm nay của chúng ta. Xin mời quý vị ở lại cùng để xem 2 lần đồng hồ diễn ra chúng ta sẽ quay trở lại lúc 3:30.
Hả? Cái đèn đây.